You're at the cutting edge of cardiovascular sciences. I'm your host, John Cooke. I'm professor and chair here of the Department of Cardiovascular Sciences at Houston Methodist Hospital. And with me in the studio is Dr. Lee Lai, one of our faculty in the Department of Cardiovascular Sciences at Houston Methodist Hospital. And today we have a very special guest. Dr. Lai, would you like to introduce our guest?
Sure. Good morning, everyone. Today we have the distinct privilege to welcoming Professor Richard Lee, a distinguished physician scientist renowned for his contribution in regenerative medicine in cardiology. Professor Lee is professor of stem cell and regenerative biology at Harvard University and professor of medicine at Harvard Medical School. Dr. Lee is a graduate of Harvard College in biochemical sciences. Then he earned his MD from Cornell University Medical College. After that, Professor Lee completed his medical residency and the cardiology fellowship at Brigham and Women's Hospital and Harvard Medical School in Boston. Currently, he leads the esteemed cardiovascular program as a Harvard Stem Cell Institute. Professor Lee's research lab investigates heart muscle regeneration following injury, as well as the impact of aging and metabolic diseases on cardiac pathophysiologies. His lab is dedicated to translate this insight into innovative therapies, including stem cell transplantation, as well as novel biological agents. In addition to his groundbreaking research, Professor Lee is a dedicated educator, teaching undergrad courses at Harvard College. He also maintains an active cardiology practice at Brigham Women's Hospital, further demonstrating his commitment to both academic and clinical excellence. So, Dr. Lee, welcome to our show.
Thank you very much for inviting me. My pleasure.
Rich, it's great to have you on the show. Thanks for joining us. And we're looking forward to hearing what you have to say about GDF11. But before we get started on that regenerative talk, tell us a little bit about this department that you're in, the Department of Stem Cell Biology and Regenerative Medicine at Harvard College.
So it's a quite unique department because everyone is interested in regenerative biology, but we work on different systems. So people work on the pancreas or on the uterus and skeletal muscle and the brain. And so we work on different organs, but we're all interested in similar sorts of things. And so it's a unique place because there's about 22 of us who have overlapping interests, but we also have very different backgrounds and very different techniques. And we teach a lot of undergraduates, and so we try to educate the next generation.
Mm-hmm. That's great. Now, in this group that you're working with, you're one of the physicians in the group, and I know that you've got an interest in translating those fundamental insights about stem cell biology into therapeutics. And tell us what your department is doing with respect to translating fundamental insights toward therapies.
Yes, so there are a lot of companies that have startups that have spun out of our department, including, for example, one of the most fascinating ones is Doug Melton, who started putting beta cells into humans for type 1 diabetes, and that work is going extremely well. And so pretty much everyone has some translational interests. And so there's a lot of business and biotech community in Cambridge, and that's one of the interesting things about the place. There's both big pharma research, but also lots of small biotechs. And so there are just lots of interactions and meetings. And so we view translation as part of science. And in the old days, it used to be viewed that it was not the same thing as academics, but we view it as something very similar.
Right, yeah, we have a similar approach here in our department too. We want to make fundamental insights and then translate those into potential new transformative therapies. That's wonderful. Rich, we have people listening in to the call, and I just want to let them know how they can participate and ask questions. So I'm just going to take a moment to let them know how to do that. So you can join us by text, and the best way to do that is the number is 37607, and text DeBakey, DEBAKEY. Text DeBakey to 37607, and then you can just simply text us your message or question. Or if you're at your computer, you can go to pollev.com, that's POLLEV.com, and enter DeBakey, and that'll allow you to ask us a question. I think Dr. Lai has a burning question for you.
Yes, as I introduced Dr. Lee, I found you committed to multiple aspects, including research and education, and as well as clinical practice. This seems a lot to me, so I really wonder how you maintain a balance among those different aspects.
It's a great question. I think it is getting harder. There was a time when it was a little bit easier to do in terms of mixing education and research and patient care. I think now it's getting more difficult to do that because everything is requiring more time and energy. For me, it's just been that I've been able to continue doing them and sort of switch focuses a little bit sometimes, but keep things going. And it's because I believe that they're really the same thing, that we use different tools and day to day we do different things, but teaching and research and patient care are really the same thing. We're just doing different activities on that given day. So I'm hoping that even as life gets more challenging, that we'll still be able to keep them going in that way.
It is challenging to do all three, and I mean, it used to be the modus operandi at the Brigham, the triple threat. You did research, education, and clinical care. But like you said, it's getting more and more difficult to do all three because each of those fields has gotten more and more complex, and to be at the top of your game, you've got to deal with a lot of complex technology and know how to utilize it.
Yeah, but if you can sort of have one thing helping with the other, so being inspired by the patients you see and learning new questions by the teaching that you do, then it can work. So hopefully the interface between them is going to allow people to continue crossing over when they feel the inspiration to do that.
You know, the one thing, you have an advantage, though, don't you, Rich? Because you understand the clinical conditions, so it does guide your scientific inquiry. So when you're doing basic research, you tend to understand the direction that you're going in because maybe a little bit better. You have that clinical perspective, so you kind of understand what questions are going to be important ones.
I do think there is a little value to that because I mean, when you do patient care, there's a lot of just things that you have to do, and they're not, you just have to get them done, and that's part of the job. But also, there are times when you think about which direction should I go in the laboratory, and your clinical expertise can help you know whether or not that's actually an important direction. Sometimes I see people who don't have exposure to the clinical world work on something that doesn't really have an outlet anymore because of how things have changed, because the clinical world changes very quickly, just like the research field does. So it can be done, I think. It's just getting harder, like maybe everything in life.
Shall we get started then, Dr. Lai? Well, why don't we, on that note, why don't we go ahead and listen to what you have to say about your basic research program, Dr. Lee. Looking forward to hearing about GDF11.
Great. So I'm going to share my screen and put it on. So I hope everyone can see that.
Yeah, I can see that well, thanks.
Okay, so I'm going to talk about one part of my lab that's worked on this project, GDF11 and cardiovascular disease. And if you're bored by it, this has been very controversial for a decade. And if you're bored by the science, then I'll just talk a little bit about dealing with a very controversial topic and how you actually might approach that. And I think that no matter what you work on, that sometime you're going to bump into a controversy. And so this has been one of those things. It just happens that it's been a highly public controversy. So it started over a decade ago when we did this experiment. And the experiment was to ask the question of whether or not there was something in blood that could regulate the size of the heart as a mouse grew older. And what you can see here is that we did this by a technique called heterochronic parabiosis, where you join a young mouse like a conjoined twin with an older mouse. And then these are all the controls here, old versus old, the old mouse alone, young versus young. And then we took out the hearts. And what you can see is that the old mouse grows bigger, but also its heart grows bigger. And the young mouse's heart is smaller. But when we actually made the mice into conjoined twins, the young mouse's heart didn't change, and the old mouse's heart came down in size. And so that made us think that there was something in blood that actually was causing the heart to get smaller. We then went on a very, very long search for a couple of years, and we identified a candidate protein called GDF11 out of a proteomics screen. And when we gave that mouse recombinant GDF11, then the mouse's heart came down in size. Now, this experiment, as I'll show you, has held up over time. However, in some of our discovery process, we were misidentifying the GDF11, which was probably GDF8 at the time. And that was one of the things that started the controversy. So the end result, which was the GDF11 could actually have effects in aging models, was true, but some of the things in our initial paper were not true because of some differences in the reagents. So what is GDF11? It's a member of the TGF-beta superfamily, a complicated and essential group of signaling ligands. And GDF11 is over here in the activin group. It's very closely related to myostatin, or GDF8, which is the other name. And at the time, many drug companies were making drugs to block myostatin. And so the controversy arose because the concept that GDF11 could be good was very counter to the idea that myostatin was bad, particularly because the proteins were so similar, and they were so similar in amino acids that it was felt that they were probably basically the same. So very controversial to start, and then I'll tell you how the story began to unfold over the ensuing years. But first I'll tell you a couple of key things. When GDF11 is made, it's made as an unprocessed pre-pro complex. The signal peptide sequence is cleaved off, and then a furin peptidase cleaves off the mature domain to the pro domain, but they stay locked together. They stay in a dimer that's covalently bound, but the pro domain stays as an inhibitory domain and prevents the signaling from occurring. In order for the signaling to occur, a set of proteases called toll-like proteases have to cleave the pro domain, and that creates a triggered or activated state, and then the pro domains can fall off and then signal as the mature ligands. When that occurs, the mature ligands bind to the type 2 and type 1 receptors, and then the signaling pathways then occur. So this is very, very well established. But the key thing I want you to see is that there are multiple proteases, and this final protease, the toluene step, we believe is probably extremely important. Now, here's another study that we did together with Lee Rubin's laboratory here in my department. It was known for years that in part of the brain, the blood vessels would decay as the brain got older. And so on the left here with ISO-Y, that's isochronic parabiosis young, that you can see the well-formed blood vessel, but in the older mouse, isochronic old, the blood vessels had broken down. And if you do the same parabiosis experiment, you see that the blood vessels in the older mouse actually start to improve. They don't actually completely reach the young level, but they're much better than in the isochronic old. And so that suggests that something in blood is potentially crossing over from the young mouse to the old mouse. So when we did the GDF11 experiment, we found that we could actually change the blood vessels in a similar sort of way by giving a mouse GDF11. So this experiment has been reproduced many times, and you increase the blood volume, the blood vessel volume, and you actually increase neurogenesis to young levels by giving GDF11. And this will become important at the end of the talk. So the controversies that have arisen were, is GDF11 actually the same as GDF8, which is also known as myostatin? Is the blood measurement useful? Because depending on how you do the blood measurement, you get some very interesting results. And is there a role for exogenous GDF11? Is there any reason to give this potentially to a human? And so the way that we've addressed this, after really being publicly pounded in the beginning of the controversy, is to address the controversies one by one scientifically. And so I'll go through these one by one. And a substantial amount of it's published, and some of it's been publicly presented, and the manuscripts are in review. So are they similar? So they are very, very close in amino acid structure. They only differ by about 9% by amino acid. But we collaborated with Tom Thompson's lab at the University of Cincinnati, developed the crystal structure of GDF11, and modeled it against the type 1 and type 2 receptors. And we found that some of the key differences actually interface with the type 1 receptor. And so perhaps those, the proteins were not actually identical as everyone actually thought. So this is just a picture of that. This is the crystal structures of GDF8 and GDF11. In the APO form, they're quite different, but I won't go into that. And we found that these amino acids really could change the interface of the molecule with the type 1 receptor, and so they really should be different. And we did a series of in vitro experiments to test that and showed that in vitro. And one of the really fun things is we were at a scientific meeting where we had dinner together. It was one of the Keystone-like meetings. It was a FACID meeting. And 4 labs were at one table, and we had conversation, and we got, we all realized that we had very similar data about the differences between GDF8 and 11. And so we all published the paper together. And so it was multiple labs putting that data together and showing the same thing. So we've gone on to show this in vivo by switching amino acids in mice using CRISPR technology from that key domain from one place to another. And when we did that, we made mice and then found that we could adjust the potency of the ligands and make one ligand look more like the other. And that actually recapitulated the findings, for example, in the heterozygous GDF11 knockout mouse, in that there were abnormalities in rib development. And we now have preliminary data that there are abnormalities in how the heart responds as well. And so by developing the crystal structure and doing in vitro biochemistry and by developing new mice using CRISPR technology, I believe we've definitively shown that the two ligands are not the same. And that was one of the key parts of the initial controversy. So here's another side of the controversy that's been interesting, and it's still developing. A key issue is, what is this useful in blood? Because the initial thought that we had was that if you just measured GDF8, GDF11 in blood, that it might actually tell you something. Mass spec studies have not proven that. Mass spec measures the total amount of protein quite accurately, and that has not proved any value. But a collaborator and friend of mine named Peter Gans at UCSF looked at our data, and he used an aptamer that measured both GDF8 and 11 and did these two clinical studies looking at patients for 9 years in San Francisco and who had 5 years of follow-up in Norway. And he found that if you use this aptamer that actually recognized both proteins, GDF8 and GDF11, that you had very, very suggestive data that there was a relationship, and the higher that the value was, that was actually better. And so we've been very interested in why mass spec did not show this, but this aptamer that Peter Gans and our lab had used was highly predictive of future events. Now, these are two studies of 971 patients. So the data were convincing, but the mass spec data didn't show anything. And so how could we actually resolve this issue? Now, what we began to ask is it possible that there are different forms of GDF8 and 11 in blood, and that the aptamer measurements and the mass spec measurements were different? And there are many different forms that can occur in blood. There might be a little mature ligand. There's a lot of latent complex, but that there's a minority of the complex that is cleaved by the tolloid proteases. And then once that occurs, it's in this activated state, or it's antagonist bound. It's bound by a set of antagonists. So what we have done is spend about 5 years purifying all of those complexes, and then testing whether or not the aptamer actually recognized some of those complexes. And I won't go through all of these data. There's a bunch of Westerns, and we have other data, and we're revising this paper right now. But the answer basically is that the latent complex, which actually is the majority amount in blood, so the mass spec is going to measure everything, the latent complex was not detected by the aptamer, and that once the activation by the tolloid proteases occurred, then the ligands GDF8 and 11 could be detected. And so it was really an accident, a really interesting accident, that this aptamer would only measure the ligands after the tolloids were processed. And so after learning this, we went back to Peter and we said, we think your data are actually quite interesting, because it means that the activated ligand actually is the predictive factor. So together with Peter, over the past several years, we've assembled a database of 11,609 coronary disease patients followed throughout the world. These include both ambulatory patients and hospitalized patients, but if we analyze it either way, it doesn't matter. And the data are extremely similar to his initial studies. In fact, so for the composite endpoint, the major cardiovascular endpoint, the quartile relationship was that you were much better off having higher values of this measure than lower values. And the p-value for composite endpoint was 2 × 10 to the minus 60. And the p-value on all-cause mortality is 2.4 × 10 to the minus 39. So it's extremely powerful. And for future development of heart failure, the p-value is 2.8 times 10 to the minus 32. So this is really very strong evidence that the activated level of these ligands is beneficial. And we've gone on to assemble other cohorts. We now have over 18,000 patients followed for 4 years. We'll hopefully be publishing that quite soon. Okay, so that answers the question of whether or not there's a blood measurement that's useful. It's just surprising because it turns out it's not the mass spec measurement. It's actually a different type of measurement. So how about, is there any use of this? Because when in the initial side of the controversy, there was an article that someone wrote that GDF11 has no relevance to human biology. And that was obviously attacking us, but that's probably the kind of title that you should never use in biomedical science, I would suggest. So one of the issues about giving exogenous GDF11 is, well, what disease would you give it to? And one of the ones that has been quite interesting is ischemic stroke. So these are different papers from many labs, including from a lab in Houston, suggesting that GDF11 could be beneficial in ischemic stroke. And I'll show you some of our data. We did this together with a startup company called Allevion. So that was one of my initial disclosures. So this is data from 6 randomized, this is from one of 6 randomized blinded studies in rats with ischemic stroke. And the rats were given GDF11 a day after the stroke. And so the reason to do that is because in day 1 in patients, there's lots of things going on in stroke. You're trying to revascularize the area. And so the real thing that's missing in stroke is a therapy that can be given in the few days after stroke that would be beneficial for a long period of time. These are objective measurements of hind limb placement, forelimb placement, and body swing in rats in standard stroke studies. And you can see that giving GDF11 for 7 days, that the rats who received GDF11 did better in all 3 of these tests. Now, there's something here that was a total surprise to us. We're giving GDF11 once a day for 7 days, and that's the benefit occurred in the first few days. And we don't understand why that occurred, but we've seen it in every one of the studies. So I'll show you a different study. This is a different study where we're doing dose response, and we're doing intermittent dosing at only days 1, 3, and 5. And the green is the high dose. And so you can see dose responsiveness. And you can also see, even at day 5, that we're seeing separation. So whatever is going on, it's happening quite quickly. This is data that I initially thought we shouldn't even do the experiment because hemorrhagic stroke is such a different thing compared to ischemic stroke. But here's a randomized and blinded study in 22 different mice per group. These are mice with intracranial hemorrhage. And you could see the same thing, that the curve starts to diverge in the first 7 days, and that the ability of the mice, for example, to complete a walking test was statistically significantly different with the GDF11 receiving animals. And so we're proceeding now to hopefully develop GDF11 for human therapy, and we've done the toxicology on that. And we don't really understand this. We know that there are improvement in measures like vascularization and neurogenesis and myelination, but we can't explain why the effects occur in the first week because that is so fast. And so we're interested in why that occurs. Okay, so another thing that has happened is that a group of investigators that came out of the NIH Undiagnosed Disease Consortium has identified patients of heterozygous GDF11 loss of function, and that causes multi-system diseases. This includes aortic disease and cardiac disease, and we've now identified through collaborators in Canada a large family of heterozygous GDF11 loss of function mutations. And so one of the ideas is if we can develop GDF11 for human use in stroke recovery, that there is the possibility that we could potentially use it for GDF11 loss of function that causes these multi-system diseases. Those include skeletal muscle, heart, as well as neurodevelopmental and GI disorders. So here's my summary for today. There was this initial very intense controversy over GDF11, which was believed to be identical to GDF8. But we've now done experiments both in vitro and in vivo using gene editing that the ligands are clearly different at the biochemical level, and we understand exactly why they're different, exactly what the differences are in the amino acids and what they're doing. So I can't give this talk without mentioning we did make a mistake. It was a mistake because a reagent that we were using, two reagents we were using were nonspecific, or they overlap between 8 and 11. And initially we thought the declining blood levels occurred with aging, but that was actually GDF11. But what does happen is that this activated form of GDF8 and 11 very powerfully predicts future outcome in coronary disease, and that it's actually pointing us to the biochemistry of that system. So we're really excited about that. It's an incredibly powerful finding from a statistical basis. And then exogenous GDF11 has potential benefit in experimental models. And I showed you some of the data, and one of the things that we're most excited about of stroke recovery. Stroke recovery is a really tough field. There isn't anything in that space, but that's why it's most exciting, because once the stroke occurs, we just wait to see what recovery is going to occur. We don't understand why in animals the recovery occurs in the first week. That is something that we've seen reproducibly and we were completely not expecting. So we're going to have to do much more work to figure out why that is. And then finally, there's a new human genetic disease with loss of function of GDF11. And that's an area where more understanding of the protein is going to be common. And so how do you deal with controversy? Well, some of it is, it's basically going to be tough, but you have to keep going. And so this is one of my favorite memes. It's a dog watching a skunk eating his dinner. And the quote is that two of the greatest qualities in life are patience and wisdom. You really have to keep going and let the science guide you and try to resolve the controversies, because eventually science resolves the controversies and no one actually even remembers the controversy. No one remembers who hated who or who yelled at whom in public. And so you just have to keep going, because getting the answers is the most important. And so I'll thank people in my lab who've worked on this together with others, Amy Wagers and Lee Rubin, Tom Thompson, Shally Basson at the Brigham, a mass spec person, Peter Gans at UCSF, collaborators at SomaLogic who made the aptamer that we've used to study that, and collaborators at Allevion that have worked on the stroke data and getting the protein ready for human use. And of course, my laboratory, this is my lab, and I have a lot of women in my lab. I'm very interested in seeing diversity and more women in cardiovascular science. And if any of you are going to visit the Harvard College campus in Cambridge, please let me know, and we'll be glad to show you around. So thank you very much, and I'll be happy to take any questions.
Thank you, Dr. Lee, for a wonderful story, and I'm sure there's going to be a lot of questions. I got a few myself. I'm sure Dr. Lee is as well. But let me just mention to our audience that you can ask Dr. Lee questions if you simply join us by text. You can text 37607, text DeBakey to that number, 37607, and text in your message. Or join us by web, go to pollev.com, enter DeBakey, and respond to that activity. Rich, I'm going to let the first question go to my colleague here.
So,
Hey.
Dr. Lee, that's a wonderful talk. So actually, I'm very impressed by how similar this GDF8 and GDF11 in the sequence, but how different they work. So as you mentioned that you identify that those two factors have different ligand. Have you knocked out the different ligand and to see if you reapply the GDF11 or GDF8 to if any effect has been interrupted?
Yeah, so that was actually done before us by Seijin Lee, who was at Johns Hopkins, but now is at Jackson Labs. And you get two glaringly different phenotypes. GDF11 knockout mice that's lethal. And GDF8 deletion mice develop hypermuscularity. And so many of the TGF beta ligands, if you knock them out, it's lethal. But there are natural knockouts, both in humans and other mammals, for knocking out GDF8. So it's been thought for a long time that was because of regional differences in expression, that GDF8 was primarily expressed in skeletal muscle, and GDF11 is expressed all over the body. But we think now that it's both biochemical differences and it's also differences in the activations, that among the tolloids there are preferences in what gets activated, and the tolloids themselves are regulated all over the body. And so it's another level of control of complexity. We know that the ligands are different at one level, and I think everyone is accepting that now.
One of the things you mentioned was that there is an increase in the brain vasculature with the GDF11 infusion. I think it was GDF11 treatment. In older mice, you were able to see that the impaired brain vasculature was recovered with GDF11. And
yes.
My question to you is, could this be an angiogenic effect? What do you think about that in terms of, is GDF11 is having an angiogenic effect to improve the brain vasculature?
Yes, yeah, it definitely could. That's been confirmed in many laboratories. It does do more than that. So that is one attractive hypothesis, because initially we thought that GDF11 was blocked by the blood-brain barrier, and so, but then in stroke, when you break down the blood-brain barrier, then some of the GDF11 can cross. So definitely there are vascular effects, but we suspect there's probably more because we're seeing things at 2 or 3 days after the initial dose. Mm-hmm. And so that's, it's fast for a regenerative process to see things at that stage. So I would say that it's really open why this is working. But certainly vascular effects are high on the list.
If I could actually, that's great. I just want to follow on with another point there, and that is that some angiogenic factors, of course, have vasodilatory effects, and you could potentially, like VEGF. So VEGF does have acute effects on blood flow because it's an endothelium-dependent vasodilator, and it's angiogenic. So that rapid effect that you see is potentially could be also vasoactive response, then followed by a later angiogenic response.
Yes, and Lee Rubin's lab has also shown that when you give exogenous GDF11, you see VEGF levels in the blood go up very quickly. And so there is definitely a vascular story here. The question is it more than just that?
Right, sure. Dr. Lai?
Yeah, so I guess I have a question regarding how you find this GDF11. So you find this GDF11 using the natural aging system, right? But then you find everything, you find the beneficial effect will help with the heart. Reduce the hypertrophy of the heart. So do you think if you use a more disease model, and you can also identify GDF11 as the upregulation factor in the young mice versus old mice after the injury?
Yeah, so people have looked at, so what does seem to happen is that mass spec levels of GDF8 and 11 do not change. This aptamer measure that we're describing does actually go down with aging. Whether or not, what's going on with that, whether it's the tolloids actually losing activity or actually decreasing, we don't know that yet. But many studies have been done, not in our lab, but by other labs, that if you do a conditional deletion of GDF11, that it makes disease models worse. And if you give exogenous GDF11 to different standard disease models like myocardial infarction and transaortic banding, that it tends to be better. So I think that it's ultimately going to be shown as we learn more about the system that there's something going on in the dynamic range of GDF8 and GDF11 that we need to understand. And the heart failure finding in humans is really quite profound, that future development of heart failure, the prediction of that's the P is 10 to the minus 32. So it's quite powerful at predicting future heart failure. So we're trying to understand, using some experimental models, whether or not that actually is the tolloid proteases that's being reported, or whether or not it's the amount of activated GDF8 or 11 that's doing that.
It was really great, your description of how you dealt with the controversy, and I think that's one thing that controversy does, that kind of intellectual back and forth between different laboratories can actually make you stronger, right? When you get criticized for, what you're doing, and you step back and you say, well, I think, actually there's some truth to what that reviewer has said or that critic has said, and then you just do the work and really delve into it deeper, and you did. I thought that was really cool how you found that the story was more complicated than what you originally imagined, that these post-translational modifications of the protein were really critical in its function.
Yeah, I think that, I've been through two huge controversies. The first one was over cardiac stem cells, and the second one was this one. And they can be tough when they're public, right? When we first published the paper, a drug company had a press conference that essentially saying that we were frauds. And so they can be brutal and they can be hard, but you just have to remember that science is not about you. It's not about me, right? It's about moving things forward for all of us. And so we have stuck with the project. We're working on this. We're 100% sure we're on to something. And so I think that you keep going as long as I've said to my lab, you keep going until they drag you out of the building and tell you that you can't go anymore. And,
I don't think that's going to happen to you, Rich.
That's basically what I've tried to do.
Another thing that occurred to me when you were talking about your work with Peter Gantz is, you're right there in the midst of the Framingham work. Framingham studies going on for decades now and have really informed us a lot about cardiovascular risk factors from that study. Have you thought about aligning yourself with that group, with the Framingham group, to investigate using their large data set, the role of GDF11 in cardiovascular disease?
So we initially looked into some of the data that Framingham had, and what we needed was the aptamer measurement. And since the aptamer was being used in a number of clinical studies throughout the globe already, that made it accessible to us. And so we haven't found, and we haven't done anything with Framingham, but because we assembled 6 large studies, the results are compelling across all of them. But then we analyze each one of those studies individually, and the results are the same across all 6 of those studies. And so we have a lot of confidence that the human data is extremely strong, and then we have other human data that I didn't present today. So the human cardiac story is going to continue not only through the genetics, but through what this blood measurement is doing.
Mm-hmm. That's very exciting. And that blood measurement, those data that you showed us, that does provide more momentum for developing GDF11 as a drug. Tell us a little bit about that. Where's the development of that agent for cardiovascular disease?
Okay, so the initial company was Allevion, and I was the founder of that. But that was a conflict of interest. But that company ran out of money, and so I no longer have that conflict of interest. But it's being restarted now by a group of people, and so it will hopefully go into phase 1 in humans in the next year. And the product has already been made, and the toxicology has already been done. So if that occurs, then the phase 2 study would come in a couple of years, and that'll be an exciting time because stroke recovery. Anybody who does any medicine knows that stroke recovery is an area of enormous need. It's really tough because so many things have failed. But if we can actually get something in stroke recovery, then it would be really difficult to beat that. So that's the game plan for that, and I'm hoping that you never know, but it's a shot on goal for a very difficult problem, and so it's worth a try.
No, absolutely, that would be amazing. Now, is it going to be delivered as a recombinant protein or something else?
Yeah, the optimal dosage, it looks like it's a recombinant protein given as an IV bolus infusion on days 1 after the stroke, day 3, and day 5. And with that regimen, there's no toxicity, and that has worked in the experimental models. And so, the animals get better in the first week, and then they stay better past a month. So it's one of those things. If you've seen people with strokes, you just got to hope we can get something to break through in this area.
Absolutely. Did the FDA ask for efficacy studies in large animals, or was it just safety studies in large animals?
So we have an FDA advisor. We don't have the IND yet, but our FDA advisors who were in the FDA before, our approval advisors who were in the FDA before, feel that we have enough efficacy data now to get the go-ahead, and we just need to get the phase 1 data.
Mm-hmm. Great. That's excellent. We look forward to seeing that coming up in the future. Dr. Lai asked a question earlier about the receptor that's activated by GDF11. Is it possible you could do a small molecule screen to look for something that activates that receptor?
It's really it's difficult because of the shapes of the receptor, and also the receptors are promiscuous. There are 33 TGF-beta ligands, but they actually funnel down on a smaller number of receptors. And so there's a lot of crosstalk between the systems. And so it's possible that one could take that kind of approach, but we just haven't done that. We're going for the natural ligand.
Wonderful. Do you have any other questions, Dr. Lai? Well, this was a great story, Richard. Thanks so much for sharing your work with us, and best of luck for the commercialization of the idea. I mean, as a physician scientist, I personally feel that that's really a noble undertaking to try to take your research insights and translate those into something that's going to be useful for people, and we certainly need something for stroke. So thank you for doing that work. Congratulations, and thank you for joining us today at the cutting edge of cardiovascular sciences.
Thank you for having me. Bye.
Thanks, Dr. Lee.